I do have a couple disclosures that what I'm talking about I had worked on since I was a fellow, so over 10 years ago. Since then, a company called Cortex has commercialized it to OnQ prostate, but I'm going to be speaking about it more in my research. I have an R01 on the topic, and we're doing some really interesting work with this. So I think we're going to answer some of the questions actually that at least provide some opportunities. I always had the same thing that we're all struggling with the same stuff with MRI sequencing, so I think this might provide, and Dr. Turpe already showed this slide with PIRADS 3. This is the positive predictive values, right? They're all over the map. So how do we address this MRI quality issue? So when I look at apparent diffusion coefficient, other than our radiology colleagues that were up here doing an amazing job, what Ralph Klayman would say, this is a snowstorm over Iowa. Basically, it's really difficult. There's different globs here. I don't know what's what. When I'm in the clinic trying to show a patient something, it's very difficult to say, oh yeah, that's it. Some of us that read them a lot can do it, but a lot of the, just pulling this up in front of a patient, you have to have a lot of confidence to do that. And these ADC maps can be, we talked a lot about that earlier, there can be a lot of distortion. And there can be blood clots or inflammation that can impact these things. So the title of it, right, restricted water. So there's kind of three components of water that impact the MRI. So there's that free water that just freely can go wherever it wants. There's this interstitial water where if you have more cells, then it blocks it and it kind of reduces your ability, and you can see that ADC drops down because you're blocking more of that free water. And then lastly is the restricted water. So this is the water within cells or within nuclei, and it just cannot get out, so it's trapped. So if you see over time, it'll move a little bit, but then it's restricted, it can't move anymore. So those ADCs will come down, and there's certain curves that you can use. So can we take a judo move and use MR, these properties against itself? And so this is just this nucleus to cytoplasm ratio. Those nucleoli are even more restricted than the cell's intracellular water as well. So there's different components of how we do this. So everybody does their MRI sequences very, very differently. So I was taking the approach that we would go all the way back to the MRI sequence and how do we actually acquire those images. So the first is there's RSI specific sequences. They're usually less than 10 minutes. They're about 5 to 7 minutes added onto the scan. Then these can be reported in as DICOM images into your PACS. These get uploaded to software, and then using that image, you can overlay it back on the T2 image. So you can see the bright image there, and then I can show that to a patient and go, oh, there's a tumor that we're talking about. So it's using this compartmental filtering. Geometric filtering is that little small blue cell, or those little small cells are more likely cancer, and columnar is blood vessels and nerves, and it can distinguish between those two things. And then this taking advantage of the intracellular or nucleoli trapped water. So this is what you kind of end up with. You have your conventional imaging, so our radiologists are happy, we're not messing with their stuff, and we can add on this extra, I say DWI, or diffusion weighted imaging on steroids, essentially. And this overlaid map, and then we've done a bunch of whole mounts to line them up to make sure that these match up. And so this was one of the earlier papers that we did. So each Gleason score has a kind of a brighter and brighter, more active restricted spectrum image, and these are compared to whole mounts. And so when we compare it to ADC, we do see that there's an improvement in detection of clinically significant prostate cancer. And when again, they match up with the whole mounts very nicely. And so what about, really what I wanted to do, and I call it a Hounsfield unit for prostate cancer. How do we make this a real imaging biomarker? How can we take the region of interest, circle it, give us a number? We do it with ADC, but it's not a great number. We don't necessarily use it clinically. So we've done that. We've created these maps, and now I can take those specific numbers and put them into a score, and we can see that by a Gleason score that it increases. So can we get to a point where we can use this clinically? So then we took, and God bless the pathologist again. We have some great people doing this work, but voxel by voxel. Can we see the images on MRI, line them up with the pathology images, and make sure that these are truly higher grade, and what that color pattern looks like? What's that heat map look like? And so we've shown a pretty accurate description of this through this paper. And there's one small component about MRI that kind of gets overlooked. You know, when we have a B0, we do this phase encoding. And so you'll pick, you know, your tech will just pick right to left or left to right. And there's this little button on there. And so when they do that, what they're doing is they're imaging different waves, different sequences over time. And what happens is they take these pictures over time, and it's like taking a paintbrush on a glob of paint and kind of spreading it one way. So everything will be a little bit shifted one way. What you can just simply do is click the left to right and go the opposite direction, and you can correct it. And this was a paper that you can, just by the MRI, you could be off by about almost a centimeter, so 12 millimeters. So when we're planning our fusion techniques, if we haven't done the MRI correctly, we're already behind the curve. So I think this is an important concept that I think will become more important as we go. And so we published this in active surveillance men. So these 3 images are all PIRADS 4 lesions. So I think then we overlaid the RSI images on them, and we can see the numbers. So if you see the RSM, which is the 3rd line down, so you see the PIRADS 4, and this RSM is restricted spectrum map. So those numbers will then correspond to a higher and higher level, giving us that biomarker aspect or imaging biomarker. So we found that this was really helpful. So the images itself, so when we're talking about the biomarker, we want to compare it to background tissue. So the background is blue, the lesion is red, and so when we look at the MAP scores, or those numbers along the bottom, when it's a benign lesion or it's a false positive, those will overlap. And the farther apart those 2 numbers are, the more likely that there's a clinically significant cancer there. So we talked a little bit about inflammation as well. So before I had some of these images, we did some targeted biopsies, and we kept getting these inflammatory markers or inflammatory stains on our biopsies. So these would be a bunch of false positives, and the red is high PIRAD scores. So I wanted to look to see if this RSI imaging could potentially obviate some of those things. So we wrote this paper. So ADCs on the left. So the orange bars are the inflammatory lesions, and the blue are normal. So if there's no upgrading, so between upgrading and no upgrading, there's really not much of a difference. The only thing that showed is if you had high-grade tumor with inflammation, that you got a lower ADC score, whereas the RSI was really low when we saw no upgrading, and both of them were high when we saw upgrading. And we've tested this against multiple other biomarkers, and RSI does seem to perform really, really well with an AUC, and the highest one is this one right here at 0.9 for AUCs. So I wanted to do one quick case. So this was, you know, I think one of the biggest issues is that this implementation of imaging has to go through acquisition, then it has to go to radiology. So this gentleman had a doubling time of his PSA. Here's his MRI. The radiologist circled this lesion, and it had some moderate RSI. And then this other one they mentioned in the report, but then they didn't circle it actually on the urinav component. And that day we also had Coelis there. So we were able to take this image, which wasn't circled on our urinav by radiology, so you always have to review your images. And then we were able to import this directly in without any other manipulation. We were just able to really import it right in and do our biopsy, and that was the only lesion that was clinically significant on our biopsy. Everything else was benign, including the other lesion. The Decipher score was high. So in conclusion, you know, I think RSI is a very novel product, and it could help with some of the things that we talked about this morning, reduce false positive rates, improve distortion corrections, and then can be incorporated into, we did it with Coelis already, but I see it being incorporated into many other technologies. Thank you.